So toxicities, infections is the number one. When we give that much of chemotherapy, the immune system kind of reduces to zero. On our units, we don't have to put patients in those like airbags or um, like no visitation like that, but we definitely have to control the environment. We have to watch out for infections very, very carefully. We monitor for different viral activations. We give antivirals, antibacterials, antifungals, and if there is any concern for infection, we go very aggressively about treatment right away. Graft versus host disease, which is, as you remember, the it's a disease that happens, or it's a complication that happens when the donor cells start affecting the recipient organs. So it comes in two forms. Acute forms affect liver, GI tract, and skin. So it can be really bad rash, diarrhea, or liver problems. Used to happen about 30 to 50% of cases with the post-transplant cyclophosphamide. Its incidence is slightly lower now. Severity has definitely become better. Happens within first 100 days, and then it's a clinical diagnosis, and it can come in different forms: skin rash, GI tract abnormalities. We have different scoring systems for that. Treated with steroids, or second line treatment is something called ruxolitinib, which is another immune suppression. Chronic graft-versus-host disease used to be a big problem again with the it affects up to 30 if affects 30 to 70% of patients in different form of severities. Again, with post-transplant cyclophosphamide, the incidence is becoming less. And then it is kind of like chronic autoimmune disease, more like lupus or multi-system connective tissue disease sort of diseases. Um, and can affect various different organs, and very difficult, very problematic to treat when it happens. So that's why these new immune suppressions that are coming are great, that they're decreasing the incidence of this disease. So just like any connective tissue disease, it can affect any organ: skin, eyes, GI tract, nails, lung and liver are the big problems, and they used to be the real cause of death in patients after transplant due to chronic GVHD. Again, treated with steroids, ibrutinib, and there is a new drug, balmucidil, that are working really well against these chronic complications. Lung toxicities are important. Other toxicities, especially during hospital admissions, are important, which include malnutrition, mucositis, a special sort of liver disease called veno-occlusive disease, transplant-associated microangiopathy, cardiac disease, and then a whole lot of long-term complications that we watch out for. As I said, if the patients live at 2 years in a big CIBMTS studies, 10-year survival was 85%. The problems that happen after transplant, acute GVHD, or the disease relapse or infection, these are the three big reasons of patients not doing well, unfortunately. But once we have control of these things, then we have patients in clinic that live for many, many years, but still we have to watch them for any secondary complications or other problems.